All right, in this explainer, we're diving deep into Perthes disease. This is a really key condition in pediatric orthopedics, and something every clinician needs to have a solid grasp on.
So let's start with the absolute basics. What exactly is Perthes disease? Well, you might hear it called Morbus Calve-Legg-Perthes, but at its core, it's an idiopathic avascular necrosis of the proximal femoral epiphysis. That's a mouthful, I know. But in plain English, it just means that for some unknown reason, the blood supply to the head of the femur gets choked off, and the bone tissue starts to die.
Okay, so how does this actually show up in the clinic? Let's build a picture of the typical patient and the key signs you're going to be looking for during an exam.
This is crucial. You're looking for this classic triad of signs. First up, the gait. You'll often see a Trendelenburg gait, that telltale hip drop, because the abductor muscles are weak. Second, when you get them on the exam table, you'll find a really noticeable limit to their hip's range of motion, especially when you try to internally rotate and abduct the hip. And third, and this is a huge clinical pearl, so listen up, the pain is very often referred to the knee. This is a classic trap that can send you on a wild goose chase, looking for a knee problem when the real issue is in the hip all along.
And this really paints the picture of our classic patient. We're talking about a young child, usually a boy, typically between the ages of 3 and 8. So remember that clinical pearl. If you've got a young boy who comes in with a limp and he's complaining about knee pain, your alarm bells should be ringing for hip pathology, and Perthes should be right at the top of your list.
So once you have a clinical suspicion of Perthes, what's next? We turn to imaging. X-rays are key, not just to confirm the diagnosis, but also to figure out where we are in the disease process. And this progression follows 4 really distinct radiological stages, which were first described by Waldstrom way back in 1922.
This step-by-step progression is absolutely fundamental. It all starts with the initial stage right after that vascular hit. Then it moves into the fragmentation stage, which is where that dead bone structure starts to get weak and literally collapse on itself. After that, we get to the Reossification stage, where the body starts laying down new, healthy bone. And finally, there's the healing or remodeling stage, where that new bone slowly reshapes itself over several years. Pinpointing which stage the patient is in is what drives our entire management strategy.
Now this is a really big deal. This specific radiological sign, the crescent sign, is what you're looking for. It's essentially a subchondral fracture. You'll see this thin, dark line of lucency just under the articular cartilage on an X-ray. Seeing this is the hallmark that tells you the dead bone has lost its strength, and we are officially entering that critical fragmentation stage. All right, so once we've identified the stage, the next big questions are, what's the long-term outlook for this hip, and what's the gold standard for treatment right now? The way we approach this has really changed quite a bit over the years.
This slide right here is absolutely critical for understanding how we manage Perthes today. For prognosis, predicting the outcome, we use the Herring classification. This system focuses entirely on the height of the lateral pillar of the femoral head during that fragmentation stage. Now, why the lateral pillar? Because it's the main weight-bearing part of the femoral head. So if it collapses, the long-term shape and function of the hip are in trouble. The more it collapses, the worse the prognosis. So on the treatment side, our goal is something called containment therapy. The whole idea, pioneered by Dr. Salter, is to keep that softened, vulnerable femoral head tucked deep inside the acetabulum. We use the socket of the hip as a natural mold to help the head remodel into a nice spherical shape as it heals.
So how do we actually get that containment? Well, the modern standard is usually surgical. The main tools in our toolbox are osteotomies, which just means we surgically cut and reposition the bone. We can do a femoral varising osteotomy, where we change the angle of the femur itself to point the head better into the socket, or we can do a pelvic osteotomy, like the famous Salter procedure, to basically create a better roof over the femoral head. And sometimes, in more complex cases, we might need to do a combination of both.
Okay, that was a lot of information, I know. So let's boil it all down into the most important take-home messages that you can bring right into your clinical practice.
These are the 4 points you absolutely have to lock in. First, the cause. Idiopathic avascular necrosis in a kid. Simple as that. Second, the presentation. Always remember that classic triad, and especially that sneaky referred knee pain. Third, prognosis. It all comes down to the height of the lateral pillar during fragmentation. That's the Herring classification. And fourth, treatment. Today, the principle is surgical containment. We use an osteotomy to hold the femoral head in the acetabular mold as it heals.
And this really leaves us with a fascinating question for the future. We've gotten really good at the mechanical side of things. We're pretty good at containing that damaged femoral head, but the next frontier has to be biological. Are we going to shift our focus to trying to prevent that initial vascular problem from ever happening? Or will we be able to develop new therapies that can actually speed up and enhance the body's own remodeling process? Answering that, well, that's where all the exciting research is headed.